What can you do to offer your patients the best standard of care?
You've got to give yourself all the available tools. The first most available tool is time, and that time costs money, so you've got to deal with that element. Probably the second most important tool that I would find way before we even start with talking technology is dilating many, many more patients.
I spoke with Nick Rumney about the standard of care he offers at his practice, BBR Optometry.
So my dilation rate nowadays is 75 to 80% of all the patients that I see. We go to the trouble of introducing new patients to the practice with a welcome letter that tells them that depending on age, certainly there is a very good chance that they will be dilated at first examination.
Nick explained that they don't get any pushback from patients, as most are symptoms-based appointments coming in via queues or phoning in with symptoms.
If they have a need for investigation, then they will have to have it done. If they choose at that point to say, oh, I don't want to be dilated, then I would prefer not to see them because you're compromising my ability to service your needs.
Does dilating patients carry any risks?
There is an awful lot of rubbish spoken about with regard to dilation. And I've seen a number of papers done, mostly have come out of the diabetic retinopathy screening service arrangements, where they look at the change in corrected visual acuity pre and post dilation. And to be honest, there isn't very much. The big change is if you've got uncorrected refractive error that you didn't know about, because somebody who's plus 150 and you've dilated them and given them some cyclopegia, they're going to not thank you very much. So you do have to be alert to that. But essentially, the main issue is retinal adaptation to glare. The retina can adapt to a wide range of levels of illumination. So as long as you've waited a certain amount of time, that's quite good. The only time, again, that's going to be a problem is if you've got significant media opacity, be it corneal or lenticular, in which case that will degrade the vision. But if you've got media opacities, you have to be dilating anyway, because how are you going to know what degree of cataract you've got?
Walk us through your standard sight test.
In a 40-minute exam for somebody that comes to see us, they will have, before they sit in my chair, they will have had eye care tonometry, and they'll have had Optos color and Optos autofluorescence as a precursor. We are just about getting back to the realms of more routine suprathreshold field testing, so we would add that in as well. They'd then sit in my chair. I'd be talking to them about reasons for examination, general health, medical history, family history, etc. I would be taking a measurement of their visual acuity. I'm a little bit of a stickler for taking a measurement of unaided visions as well. I am quite OCD and pedantic about things like that. Once that's done, I'm going to swing the slit lamp across. I already know what the pressures are. I'm going to swing the slit lamp across. I'm going to have a look at the anterior chamber, the front of the eye, make sure there's nothing immediately obvious there. Once I've moved the lights away, we'll maybe have a look at their pupils. We'll maybe have a look at their ocular motility and muscle balance. I then put in a drop of 0.5% tropicamide in each eye, move straight onto the refraction with an automated phoropter. And to be honest, I don't know how you can exist in this day and age just continually using and seeing a trial frame as being the be-all and end-all. So we'd use the automated phoropter, and the refraction side of things, because we're experienced refractionists, is fairly quick. Way before the lenses started to react to the tropicamide, way before the pupils really dilated. So we've done the distance and near refraction. We've compared it with what their previous correction was, because we've already dialed that in. We make a decision on prescribing at that point, and then we swing the instrument away, have a little bit more of a conversation, and then we would walk down the corridor, pop them on the OCT machine. I would do the OCT scan, though we're moving to a system where our technicians, our clinical assistants will do it. Move back to the room, open up the OCT file, because at the end of the day, as long as you've got a reasonable size of pupil by now, which we usually have, you'll have a great OCT image. You've got your Optos images. You talk through the images with the patient, and then you swing the slit lamp across, you bring out your Volk lens, and you're looking through a near fully dilated pupil as much as is necessary. Now, the downside to that is it compromises us if we want to use something like a DNI aberrometer, which we're going to start integrating into preliminary assessments. So there will be some degree of auto refraction prior to seeing the optometrist. And I guess you could say that some elements of the dispensing side could be compromised because they've got a large pupil.
How do you go about bringing new technology into your practice?
So it's all about the pathway. And if you have a piece of kit, you drop it in and you don't have a pathway developed, it's not going to work. And then things like, how do you integrate full threshold fields into a pathway? Well, we don't. It's not a routine assessment done in part of that pathway. They'd be brought back in for a glaucoma enhanced case finding, for example. So that's the tough bit, is getting the pathways worked out and getting consistency across maybe 4 optometrists, where you sometimes will end up with 5 opinions. It's just the way it is.